Okay, are there in the beginning right away questions you would like to pose on that topic, building on the framework I offered you to in the keynote I gave? Is there anybody who wants to jump in? Yeah, just one.
Yes, hello. I'm the person who asked the question that you had at the very end. I work with Indigenous children and youth in Southern Vancouver Island, and I think you made it very clear from your talk that you understand that the social determinants and the need for a family-based approach very early in development is absolutely crucial. My question really is that a great deal of what you said is absolutely true. However, this is something that involves a broken collaborative care system, especially after COVID. And it's really about allyship and advocacy and trust, especially with the Indigenous population who have generational, residential school trauma and all sorts of other issues, many structural barriers. And the fact is that we don't actually offer any kind of good treatment after overdoses, at least in this city, absolutely none that I can admit. I can tell you right now. If somebody has an overdose, people are simply very eager to get them out of the hospital. And when they're in the hospital, they don't really get care. Nobody sees their families. Nobody has a family approach. People are very eager to use Abilify and all sorts of drugs, which are absolutely irrelevant to the treatment of this child. And so the kind of thinking that you're proposing is so important and I absolutely believe essential. And the only way to do it is through teamwork in the community and building bridges. However, I don't see much willingness to invest in that either at a government level, and neither do I see a lot of discomfort amongst my colleagues with the current level of care. So perhaps you have some thoughts on that, because I really think this is about advocacy and allyship and building bridges within our own departments, but also with government and community.
Oh, thank you very much for your question and your remarks. Also to be transparent, I'm actually trained as a family therapist. This is what I did and what I do. And part, and this is kind of the system thinking I bring to the table. And actually, I came to Vancouver 16 years ago from Europe. And actually, I was extremely surprised not only how competitive the different arms of the system are to each other, but also how separated they are to each other. And how do you kind of create an environment of, let's say, what we say, a continuum of care, of support. If problems are long-term, if they start in early childhood or adolescence, you need to connect the dots, right? It's not just a short intervention here or there. It needs to be a long-term system of support. And sometimes it also needs a model which allows that. On a positive note, I think one system I really learned to appreciate a lot is what is done with She-Way and Fear Square. I don't know whether you're aware of that. That is a program for young pregnant and drug-using young woman who is really trying to first of all, decrease the foster care rate. So like try to help mothers or families to take care of their kids, and also be able to navigate their substance use. That is it's a real good model we have in our community, how you could do it. And it's connected to the Women's Hospital with Fear Square, where there is taking good care of the women during delivery and their pregnancy if something is happening. I think that could be a good model to learn from. And yes, I would like to see more of a collaborative approach, which means you need to agree on common outcomes, right? And in the current situation, the outcome, from my perspective, needs to be to help these kids to survive. You saw these staggering numbers of mortality, which is unheard of. It's the biggest crisis in this age group I'm aware of. So, and I'm on this planet also a few years. It's really something every professional and everybody who is working with these problems or in this area needs to be concerned of. And so you say, okay, collaborative system of care didn't really exist. That's my summary statement, and correct me if I'm wrong, didn't even exist before COVID. And if you see how effective interventions could be, and Frisquet, they were able to turn around the foster care numbers from 80% of the kids being sent into foster care to only now about 20% sent to foster care because of intense work in the community, support, peer work, and other interventions, not rocket science, really continuous support during the pregnancy, minimizing the risks, and starting to work on the critical issues we all know about. So I'm pretty sure if you work with the adolescents and young adults, or if you work with families, it's not a big surprise what kind of problems there are. And the numbers are there. You saw the CEDAR study is a good observational cohort study about First Nation. It's I wish there would be more like that also for other target groups and population. But it tells us, okay, there is something wrong in some families, and give me a break. Everybody who knows that this level of sexual abuse in childhood is extremely concerning, and it needs professional attention and needs especially a system of support to avoid taking kids away from their family of origin. Okay, that's my elevator pitch to your comment, Jasmine.
Is there a follow-up question, Jasmine, or no?
Well, it's not a question. I think that we understand exactly what Dr. Krause is saying. I don't even think it requires more research. What it requires is something quite different. And my frustration is that not only are we losing child psychiatrists, but we have to do some task shifting. That is, there have to be other people besides psychiatry in mental health who have a family orientation, and there's just not any support for it. And I have to tell you, the social workers I work with are all young. They burn out in a matter of months, and then there's somebody else there. So it's about 5 social workers per terrible case. And I mean terrible cases, whether the child is 4 or whether the child is 15. So I really believe that it requires advocacy and some kind of cohesion of mental health together across disciplines. And I don't know how to do that. I just really feel very frustrated with the situation in British Columbia.
You're absolutely correct. And if you look into the housing situation, it's the same thing.
Yes, it is. It's a tragedy.
And if we work like that, you lose hope, and you lose a lot of people in the medical system. So a family approach is also not something which is just comes from let's say, a dedicated family therapy. That is a very good tool if something is really complex and you need the expertise. But mainly it's about having some people who really have a good system view to support, let's say, the social workers working in the field. And I think, look, so research is also, as a researcher, I have to protect that a little bit, Jasmine. So, sorry for that. But it's if you know, for instance, that with an intervention like She-Way, you are able to turn around the numbers in a dramatic way. You can make sure you save a lot of money because the kids are staying with the mother or with the family, and you can invest more in better support, in appropriate housing conditions, in bringing them away from survival sex trade, and all these things we closing our eyes from. And so I think, yes, we need to build capacity to do that. And yes, it's totally unacceptable if kids which are already overdosing in early age are not getting any substantial care. Like in the US and in Canada, we don't even have a study about that. So I think it's important to know, because then we can advocate also clearly how to change that and how to turn it around. And I agree totally, that needs to be a team approach. That needs to be the philosophy. And the main point I mentioned also before, we need to agree about what we want to achieve. And that is, we want to help the kids to survive. We need to want to empower them so that they are able to stabilize in a way that they can make all these complicated transitions in adolescence and young adulthood without failing totally.
Thank you. Is there anything you want to say, Jason?
I'm a researcher too, and a clinician. I have no problem with that. I'm just, my point is that when you have the research and it has serious implications, I think the next step is advocacy to make it happen. So that's where I think we have a great problem.
And we are agree on that, and we will both work in that direction. And if you see the overall composition of our conference here, you see that we try to bring to bear the best evidence to actually support a paradigm shift in our system. Grace.
Yeah.
Hello, I hope, can you hear me?
Yes.
Oh, good, because I had trouble before. You talked about silos. I mean, I worked in health, and I'm a retired nurse, and I worked in mental health. There's a tremendous, since child and youth went to the new ministry, the children and families, we were divided then from the adult program in health. And prior to that, we were able to do more family. We didn't have a silo. We were able to, from children's program to adult, to be able then to provide that family piece that we need for the parents and for them individually and then for family. What I'm seeing is there's such a disconnect now. And so we need, in our rural communities, we need to know, how do we break down that silo so we can have that connection in order to provide the services we require. Through the children's system, it's just the children, the child and youth mental health program are within the whole Ministry of Children and Family. There isn't, it seems to me, no system on how to do this family piece that we need to do, unless they're contracting that out. I don't know, but our concern, I know our concern from our community is these silos, and we're just having a terrible time breaking them down. And our youth, our child and youth, I have seen the deterioration is serious, more than serious. It's disastrous. So
which part of
I come from the Okanagan.
From the Okanagan, yeah.
And
yeah.
this,
I don't, the minister this morning said that youth is a priority for them in the mental health and substance use disorder ministry, or in the Ministry of Health too. Look, how I see it, I don't really, I was unable to identify a real strategy so far. So looking at the numbers from the United States, which were published, and we presented that also during a conference here, so the majority not getting the basics. So under 10% are getting some kind of follow-up care. Let's not talk about even family involvement or quality care or long-term support or whatever. It's not. So it's definitely not a priority. And if we see, actually, I'm really kind of really disappointed there and angry. If 6 people are dying per day, and one of them is an adolescent or a young adult every day, and this is happening now for about 3 years, then something is substantially going wrong. If that would be the case for cancer care, for instance, or any other major medical intervention, there would be riots in the street. But we are kind of we still on our our patients are on their own in this this struggle. But so that's kind of, it's repetitive. It's the question is, how can we? So how should the system look like, and how can we also jointly put pressure on decision makers, on health authorities, and on our colleagues to connect and to create a system which is clearly measured also in its resource allocation towards outcomes, better results. We need to shift the development around, because otherwise it's just commenting on the misery. That's not so constructive. Okay, yeah. Are there any other people who like to show themselves and contribute to our wonderful discussion here? I always wonder why it's so. It's much nicer to see you and to have a conversation eye to eye, and most people are really more comfortable not to be seen. You can drink coffee, and you can have even a glass of wine. Nobody would criticize you for that. Okay, any comments to the discussion we just had in the beginning? Okay, somebody is showing up. Here is Mike. Thank you very much, Mike. Do you want to jump into this discussion, or shall we? You want to warm up a little bit? Okay.
I'm enjoying this session very much. Thank you.
Thank you. Positive reinforcement is also so important for the speakers and for the discussants. Thank you. Okay. Then let me share. So there was some. Are you Arash? Are you controlling the chat?
Yes, I am.
Okay. Okay. So I will share some of the slides I already shared. I hope I can do that. Okay. This is here we are. I want to come back with one topic which is kind of interesting. Also, if we discuss about right now about substance use disorder in British Columbia, especially, we have a very variety, very different perspectives. variety of models of substance use. So models, which are some of my more coming from a functionality perspective. So why are people doing what they are doing? And interestingly, the question, why is somebody using opiates? Why is somebody using too much alcohol or whatever? And why are they doing what they're doing? Is very often not in the focus of our discussion. It's more kind of, it's like a given, okay, that's a disease, and the best way to address it is to give them the psychotropic substance they want. So functionality of why are people also cutting themselves or self-harming or trying to kill themselves is not really a question in the treatment system. And actually, what I wanted to mention again is that the therapeutic system and all interventions are competing with the coping mechanisms and with the coping behaviors people are choosing themselves. So therapy is in competition to your individual coping strategy. And if the coping strategy is very harmful to yourself, then the treatment system and the interventions need to be especially engaging. So they need to provide more advantages. They need to provide more perspective than the coping strategies you are using or everybody is using. So that's the reason I think it's also what the young women in Chihuahuas are learning, that having a child is a lovely opportunity to. It's not just a burden. And is they learning that not to break down under the hassle of bureaucracy and not having a place to live and not having a partner you can rely on. So to resolve really basic problems. And I probably you remember this very impressive case story Dr. Azar presented and shared with us. This individual stabilized after he was able to establish a partnership. He stabilized after he had a really good, understanding, warm-hearted physician, listening to him, taking care of him, not judging him. And these are really also, and then he also shared his, so that always if he was under big pressure, he became psychotic, and then he tried, obviously, to calm himself down. And then he had pain because of his job, and he tried to self-medicate himself. So why am I mentioning that? I think that was without me, let's say, initiating that case story. It was a really good example how the burden this person is feeling and is bringing is contributing to his strategy and his lifestyle, and also the risk he's willing to take or is willing to tolerate. And you're probably all aware of people who at some point of traumatizing lifestyle and lots of pain, lots of emotional pain, they don't care. They start, so, and they're getting numb, and they're getting really they don't have the appreciation for life, for development, for future, and all the things which are driving you doing this. Okay, that is thing. So, and then if you offer them very different models of substance use, like it is recreational or it is, let's say, a biological dysfunction, then you end up in a very controversial situation. The recreation, which is certainly a non-health related topic, or self-medication, which definitely needs a decisive approach in terms of better healthcare, better intervention, better treatments, addressing the needs of these users. So this is what I wanted to, let's say, kind of repeat a little bit in order to really support a shift in perspectives. So I'd like to say that if we are able to really read our clients or our patients or our tenants and understand what the key challenge is for them, then the likelihood to be able to address these and to work with them into their direction, helping them to realize what they want to realize. That's I think the success, the likelihood of success would be much bigger in that case. What do you think about that? All these smart people are now so silent. Grace, thank you for helping me out. I don't know what to do.
Well, you know, that's really, it helps us to understand and the approach to use. But I don't want to put a button here. What I have seen, because with COVID, and we look at the ministries, it seems like everybody is so tired, and so things are so toxic within their system because of some of their policies and procedures, and they're outdated, and there's so much hitting them because of being so tired. I'm wondering if our clinicians are so fatigued, and maybe that's why they're not responding today, because they don't know even where to start. Do we need, my question is, because of COVID for the last 2-3 years, are we needing to help our clinicians first, our first responders, and everyone that's on the line here today that's not responding? Are they needing this self-care and the care? Do they require more care so that they can come out and start doing, helping the community? Because it's a question I've been wondering. I've been watching this, and I'm really concerned for our workers. How are they doing? How are they managing? And then they see this as a really complex issue of how do we treat this intense disorder, because we're looking at concurrent and all this. And what are the stumbling blocks for people to start coming forward and be, you know, to get some satisfaction with a little bit of work, even if they see a little positive with a person, they'll give them some hope. But that's what I'm wondering. Are we dealing with two things here? We've got a serious, you know, the whole thing about the overdose and stuff, and then we have tired people. So that's just my question. I could be wrong.
No, it's a very appropriate, adequate observation. But if I wouldn't tie it too much to COVID, because COVID was an additional stressor, yes, yeah. But the society in general throw a lot of resources towards that. Yeah. Billions for medication development, for reorganization of the healthcare system, and so on and so forth. The interesting thing, if you look in the population we're discussing here right now, there is nothing like that. It's absolutely amazing that, for instance, the US declared also the state of emergency, I think 2016 or so, and they didn't provide any additional fund to address that emergency. It was kind of a demonstration of ignorance of the highest degree. Yes, if you use the family model we discussed in the beginning, you're absolutely right. It's I'm totally convinced you need to take good care of your teams, of your professional, of your experts. Otherwise, they leave, or they don't have the strength and the endurance to stick with problem solving and to stick with really and being as engaged. And if you look at that doesn't not necessarily very often not even need to be let's say economic attention or better pay. It's also to acknowledge what they are providing and what kind of critical role they are playing. My sense is that very often, like in dysfunctional families, in the dysfunctional organization, the medical professionals, the social workers, the nurses, or whatever, are not appreciated as they should be. And they are not, I say, getting also the influence and the impact they should have. So, and it's a little bit like family dynamic. If you're not doing that, then the likelihood that somebody is leaving or is not working just or is not really productive, but more or less hiding in the bushes is very high. And everybody who is hiding in the bushes is increasing the load on others who are really committed to what they're doing and think that they can do a good and a sufficient job. Yes, Sophia.
I think, Doctor, can you hear me?
Yes.
Yeah, I think you did in the right place. The reason is because I really believe that this is a systemic problem, and the system in general is corrupted. And we have to say it clearly and loud, because this is not about COVID thing. This is not about pandemic and tiredness, or because we drain all our energy dealing with a very vulnerable population that was in the highest risk of the infections that we face for 3 consecutive years. This is about a system that is not hearing the voices that you express here. Family matter. And in this country, the educational system and all the system has been separated for years. This concept in our operations. I happen to work as a harm reduction worker in Ottawa, and I have a son who suffered from mental illness, and I had to fight, literally fight, with a system and quit my job from Aboriginal communities to come to Ottawa and ensure that my son has the proper care and the proper healing. I was denied in the most nasty way, not once, not twice, several times, from family doctors, psychiatrists, and even president of hospital to be involved in my son's care. And why is the reason? Because my son happened to be now an adult, which is right. And I agree with the freedom that an adult must have because it's also their human right. But it's important to understand that when the family support is out there, and is ready to provide the service or the involvement that is needed in order to this family member to heal, they have to be able to listen. And fighting against system is not an easy thing. It's very complex. And that's the reason that I use the word corrupted, because I don't know other places. I work in 7 cities in this country and living there for work purpose. And I can tell you, Ottawa is completely different. In here, everything has a political dress. And this is, for me, something new that I had to get familiar with to navigate the system. But at the same time, when it comes about death and life, like the overdoses that we are talking about, it's important to get together, as the other lady said, being able to collaborate between all the people that is committed in this field, and also provide advocacy, the referrals, and the voices that are needed to be heard in Canada to change the system, because it's systemic. That for sure is systemic.
Thank you. Michael, you have.
Yeah, that's most likely true. I'm not an expert in Canadian politics. It's kind of really difficult for me to understand the process of decision making on a regional and on a federal level. The only thing I can say from my perspective, in knowing a lot of countries, I'm working, doing a lot of work internationally too, is that there are really good examples how it could look different. So, and that means, but you need to plan a healthcare system, and you need to plan an approach together with users, together with their families, in a way that you achieve the best possible outcomes. And what you can do, if you do that, is you can study in a few really wonderful examples of functioning care. This is also, so I mentioned Shiwei, and what you see here, so the expansion of, in British Columbia, the expansion of youth mental health services with Foundry seems to work quite well. And you have a commitment more and more from pediatrician, from adolescent medical colleagues, from the few handful of adolescent psychiatrists. So it's a mix. It's a totally underdeveloped area, little attention, and the collaboration is not as effective as you would like it to be. So I agree with your analysis, but I don't really understand the rationale. Why? Is it stigma? Is it ignorance? What is it that makes it so complicated to respond to an overdose crisis effectively? Yeah, Arash.
Thank you, Mike. So there's a question from one of the audiences. Do you have any suggestion for how to manage issues of chronic pain for clients with known substance use struggles when doctors refuse any medical management of pain due to client struggle with addiction?
Yes, I think if a pain specialist is refusing support in his core area of expertise because a patient is using psychotropic substances, this is, I would say, is unethical. So you need to, if you're not providing appropriate alternatives to, how should somebody then cope with his physical symptoms? And so it's very interesting if you look into the overdose situation again, because that's kind of, let's talk overdose account. In the beginning, there was very often a strong criticism towards prescription drug use. And in the US still, there is one of the core hypotheses is that the overprescription of opiates is a major reason for the overdose crisis. It's very interesting. If you compare countries like the US and countries like Germany, they have or Canada, you have the same level, extremely high level of morphine prescription or of opiate prescription for pain reasons. Canada and the US have a significant overdose crisis. Germany doesn't and didn't have it before. So the overprescription or high prescription rates is a long story. That is not happen. Did not happen last year, first time. So what is the reason for that? The reason is that access to pain treatment and access to longitudinal pain management, what we call opiate stewardship, is available in Germany. It's not so much available in Canada. It's really different. You have long waiting times to see a pain specialist, and the collaboration also with mental health is underdeveloped because there's very little expertise in that area. If you have a good pain specialist like you find in VGH, for instance, here in Vancouver with the CPAS program, then your likelihood to manage your pain in a more appropriate way without high risk is much higher than in other parts of Canada. Okay, Arash.
Yeah, I have a question. The trend that the overdose of adolescents is increasing, and in the first months of 23, in January 23, the amount was almost equal to the total of 2019. So many people, in the increase in the overdose, they related it to COVID-19, the social isolation, lack of a school connection and boredom of the children. But nowadays, I think at least we are a year that we are back to normal somehow, and we don't have those situations that we had in 2020 or 2021. So how come, and the overprescriptions, we are past that, for 5 years, I think, after those, legal lawsuits. So why still we are seeing this increase in overdose and this exponential growth? Because COVID-19 is, I assume that is gone, is back to normal, the situation. People are going to school, adolescents, yeah.
Difficult question, because we don't really also have the numbers they had produced in the US in analyzing the situation. But Barbara, you want to say something? No. So what is the reason for increased overdose among adolescents?
Yeah.
I can speculate only. I think the stress is potentially part of it, but I don't really would explain it with the COVID situation. I think that is an overstretch. What I would see as it's, first of all, first thing and major thing is adolescents and young adults having an exploratory pattern of use. They are using substances with, let's say, trying out as part of their peer group. They're trying all kinds of substances, and then because of the universal availability of fentanyl, for instance, the likelihood that they're trying out fentanyl is much higher. The second reason is we don't know how many overdose attempts they survived, but the situation is especially dangerous because adolescents especially have a lower tolerance to opiates. So if they use something high potent, the likelihood that they are not surviving that is higher. And then a third thing is they very often, they have lots of connections, but their peers are not having the skills, for instance, to inject an naltrexone or help them to, in an emergency situation. A lot of them running away if one of them is having an overdose because they are scared and they're not educated. That's the reason I say you need to start to prevent crisis and fatalities through also being transparent to them, explaining them how the world is working right now and how their environment, what the risk factors are. So everybody of us also learned a few core skills in that age range. If you're not learning these skills, then the likelihood that you're not surviving is unfortunately increasingly lower. So that is a very probably superficial explanation, but we need to look in it. And the other problems, also fourth topic, the other topic is if all these traumatic experience and all these things I mentioned before are still on the same level as they were before, then the need for a self-medication is getting higher, but the risk is also higher. So that's the reason I think the likelihood of kids and adolescents, young adults not to survive if they're starting to use fentanyl or other high potent opiates is increasing, and I'm not expecting them to go down this year. Does it make sense?
Yeah, absolutely. Yeah. And Sophia is mentioning that the labs are now in Ottawa. They used to bring fentanyl from outside Ottawa, and apparently there are 35% more ODs compared to before COVID. And they are mentioning that COVID-19, yeah, they're mentioning that media and educational system is ignoring the crisis.
So what is true is, which is pretty is well known, instead of importing heroin from Afghanistan, now the regional production of high potent opiates and stimulants is becoming more the rule than the exception. So you have big labs in BC and on the west coast of the US where fentanyl and carfentanil and other drugs are produced, high quality, purity, and cheap. It's cheaper than heroin right now. It's cheaper than cocaine. So, and that is also increasing the risk. Very simple. Availability, access, quality of the product, and lack of alternatives and lack of treatment. All of that are becoming a very dangerous mix. Yes,
Is there any question?
dramatic discussion we have today. Jasmine.
I'm going to come back to what you're talking about, which is prevention. And I have done global research in Jamaica and other places where we had very high rates of drugs available and violence, very much impacting the adolescent group. And our strategy was to work with teachers and schools because the parents were not able, with their overburdened lives and poverty, to really engage in therapy of any sort. So one of the issues is, could we offer something to the children that are called bad and actually look at those children as children who have needs which are not being met? And could the schools compensate in some ways and do something different in how they approach those children. So we did a project that involved 3 years of intervention for every one of the high-risk children in several schools. The problem then becomes that the government can see the numbers, and this I'm going back to the issue that you're saying that research is important. So the government sees the numbers, the government sees that those children improved. The parents start to get engaged because now they see the children are actually functioning, but then the government has no money to sustain the support of the schools. And so you have several problems there. One is that every community is local and a small microcosm, just like a family is. So if they're not local champions, there won't be sustainability of change. And you have to put in the time over years, not 2 months. It's not a quick fix with children. And if you don't bring that base of the early abused children, if you don't prepare them for adolescence, you are into a really dangerous game by the time you get to 11 and 12. Then you have HIV, you have early pregnancy, you have et cetera, defiance. So I'm also really struck here by the fact that schools do not have enough support staff to actually deal with the children that teachers identify as being at high risk. They also we don't train teachers to be observant about the children who withdraw and the children who are defiant, who have 2 different ways of showing that they are at high risk. And we don't support the teacher if they do identify those children. So in Victoria, for example, there is 1 counselor for the whole city doing multicultural intervention for minority children, 1 person, because there's no budget for anything else. So I'm looking at task shifting, not only from that we can't expect this all to be about primary care and mental health, but also about schools and nurse practitioners. So there are many people who could be supported by government to do this prevention step of high-risk abused children, which, as you know, is a very large number of children, especially in the minority and indigenous group. So we have the research to tell us, but we don't seem to have very much political will to do the task shifting.
Let me summarize it. I think that is a good point. Let me summarize that because it's not only true for schools, it's also true for universities, for instance. We're seeing a lot of our students starting to use hydromorphone or stimulants or whatever to cope with the enormous stress they are under. So I would say you need to accept as a society, and also defining school curricula, what are your priorities in education? And I think it shouldn't be as much about knowledge than it should be about knowledge acquisition. It should be about teaching of skills, teaching of social and coping activities. And the interesting thing is, if you compare countries, for instance, we have in Europe these PISA tests all the time. So the countries which are open to that are actually the most successful also in the educational achievements. So, for instance, the Scandinavian countries, they are very, very successful in integrating different things into their curricula. And prevention is not just having 1 or 2 hours to inviting a policeman to telling the school kids how dangerous drugs are. This is not going to work. That is a failed approach. You need to help them really to maneuver their own lives, have to cope with the substance use of their parents and with all these other emotional challenges. That's the reason adolescents and young adults are the most complicated times in your life, with a lot of hurdles, with a lot of developmental challenges. And teachers as well as physicians, pediatricians, psychiatrists, and whatever, social workers, psychologists, need to accept that it's not about the current crisis, it's about how to prevent the next one and how to learn skill training. And I think that's the reason I'm talking from a paradigm shift. That's a different perspective on things. And as long as we are not shifting from crisis management to proactive support and training and psychosocial interventions, we will have very expensive but unsuccessful things. So, and now I'm called by the coordinator to shift over to the panel. I thank you a lot. Thank you especially for the fearless women here showing their faces. I really appreciate that. And I hope you had at least some fun in the common vision, and in our discussion I feel some encouragement, and I hope you stay for the panel because it will be very exciting too. Thank you very much, and I hope to see you next year.